Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes and Lecture. So let's move on further on the topic of diabetes mellitus. So till now we have discussed till the differential diagnosis, how to differentiate between different types of diabetes mellitus and how to differentiate hyperglycemia from other things like stress hyperglycemia or from diabetes insipidus. Now we'll discuss about the diagnostic approach. So before going to diagnosis, we are first focusing on screening. Okay, there are guidelines, American Diabetes Association guidelines 2026. So according to that, there are some criteria for screening of both type 1 and type 2 diabetes mellitus. Let us see those criteria. So screening of diabetes mellitus, guidelines for that. So there are two. So first, coming to type 2 diabetes mellitus. So there are two things in type 2 diabetes mellitus screening guidelines. One is universal screening and the second one is screening at any age. Okay, high risk screening. So one is universal screening and the second one is high risk screening. So universal screening for type 2 diabetes mellitus in asymptomatic adults is mandatory to start after the age of 35 years. So so it is a universal screening guideline according to 2026 ADA guidelines. So after every any adult who is having 35 or more than 35 years of age should be screened for diabetes mellitus. So what are the screening tests recommended? There are three tests. Number one is fasting plasma glucose. Number two is HbA1c. Number three is OGTT. Either you can use fasting plasma glucose or you can use HbA1c or you can use oral glucose tolerance test. So these are the screening tests recommended for screening. So that is about universal screening. Second one is high risk screening, earlier and more frequent. So this is recommended in an adult of any age who is overweight or has obesity, meaning BMI more than or equal to 25 kilogram per square meter or equal to more than 23 kilogram per square meter in individuals of Asian descent. So patients who are obese or overweight, so along with at least one risk factor should be screened for diabetes mellitus. So what are the risk factors? 5 risk factors, remember. So number one is there should be first degree relative with diabetes mellitus. First degree meaning any sister, brother, mother, father or son, daughter. That is known as first degree relative. So any first degree relative should have diabetes mellitus along with obesity or overweight. Second, or they should have a history of cardiovascular disease or the patient should have hypertension, meaning BP should be more than 140 by 90. So hypertension or history of cardiovascular disease. Third is high risk ethnicity like patient should belong to African American origin or Latin America or Native American or Asian American or Pacific Island. So these are classified as high risk ethnic individuals which should be screened for diabetes mellitus if they are obese or overweight. So patients, the fourth one is patients who are having polycystic ovarian syndrome. Patients who are having either polycystic ovarian syndrome or HIV or MASLD, nothing but metabolic dysfunction associated steatotic liver disease. Metabolic dysfunction associated steatotic liver disease, nothing but what you call fatty liver. Okay, or physical inactivity, or patient who are having acanthosis nigricans. 5 things in this. So patients who are having polycystic ovarian syndrome or HIV or fatty liver or sedentary lifestyle or acanthosis nigricans with obesity or overweight, they should be screened for diabetes mellitus type 2. Third one is dyslipidemia. So what is dyslipidemia? they should have HDL less than 35 milligram per deciliter or triglycerides more than 250 milligram per deciliter. HDL less than 35 milligram per deciliter or triglyceride more than 250 milligram per deciliter. So these 5 are the risk factors for screening patients who are obese or overweight for type 2 diabetes mellitus. So just to summarize, first risk factor is your any first degree relative who is having diabetes mellitus. Second risk factor is high risk patient having hypertension or cardiovascular disease. Third, we can say it as dyslipidemia. Fourth, patients who are having polycystic ovarian syndrome, HIV, fatty liver, sedentary lifestyle, or acanthosis nigricans. Fifth is high risk ethnicity. High risk ethnicity. So these 5 risk factors are there. Okay, this is high risk screening. That's about the screening. What are the tests? Again, same test: fasting plasma glucose, HbA1c, or oral glucose tolerance test. Okay, that's about the that is from the latest ADA guidelines. Now coming to pre-symptomatic type 1 diabetes mellitus screening and action. The action, what should be done? So according to ADA 2025-2026 update, here only one type of screening is there, that is high risk individuals should be screened for type 1 diabetes mellitus. There it was 2 types of screening: universal screening for any individual who is more than 35 years of age, and high risk screening. Here it is only high risk screening, meaning any patient who is having a first degree relative of having type 1 diabetes mellitus. So that is high risk screening. That's all. High risk individual. So what we should do? We should not measure FBS or HbA1c or OGTT here. Okay, these are not the test for screening in type 1 diabetes. Instead, we measure the, as we know, there are 3 stages of this type, 4 stages I think. No, 3 stages of this type 1 diabetes. First stage, we will have the antibodies, patient will be asymptomatic. Second stage, patient will have antibodies and dysglycemic. Third stage, patient will be symptomatic and having the antibodies. So we need screening at either first or second stage. Okay, so that is pre-symptomatic type 1 diabetes screening. So it is autoantibody based screening. So what you do, at least you should measure 2 antibodies of 3 antibodies. So famous one is anti-GAD antibody, anti-GAD 65 antibody. Second one is anti-islet antibodies. Okay, islet. Third one is anti-zinc antibodies. So these are the 3 important antibodies. So among these 3, at least 2 antibodies should be present. That confirms that the patient is either in stage 1 or stage 2 of type 1 diabetes mellitus. So what should be done? So there is a treatment developed and it is FDA approved, an antibody known as teplizumab. Okay, what this will do? So this will attenuate the autoimmune response against the beta cell. That's how it will preserve the beta cell, and it is evidence based, meaning it is proven to significantly delay the clinical onset of stage 3 type 1 diabetes mellitus by several years. Okay, it will delay the onset of type 1 diabetes mellitus by several years. It is proven. So teplizumab antibody should be given to those patients who are found positive for having autoimmune anti-B cell antibodies. Okay, that is about screening of the type 1 diabetes mellitus, teplizumab. Okay, now coming to the diagnosis of type 2 diabetes mellitus. So how do you diagnose diabetes? So first we should know, we have already discussed this thing. So for screening, we take into consideration these 3 tests. One is fasting plasma glucose, second is OGTT, third one is HbA1c. But in diagnosis, we take into 4th test also, that is random plasma glucose can also be used for diagnosis. Okay, but not for screening. So fasting plasma glucose is nothing but normal range less than 100 milligram per deciliter, and in pre-diabetes it is 100 to 125. In diabetes is equal to or more than 126. OGTT normal is less than 140. Okay, and pre-diabetes is 140 to 200. Diabetes is equal to more than 200. HbA1c less than 5%, 5.7 is normal, 5.7 to 6.4 is pre-diabetes, more than or equal to 6.5 is diabetes. Random plasma glucose normal is less than 200, and diabetes is said with random plasma glucose only when the random plasma glucose is equal to more than 200 with classical symptoms of diabetes mellitus. So if you want to diagnose patients with as diabetes based on random blood sugar, then you should take consideration the patient symptoms also. Patient should have classical symptoms, and along with that, if the patient has random blood sugar more than 200, then that can be said that then it can be said that patient can be having diabetes. So these are the thresholds of these 4 tests which are used for diagnosing diabetes. Now, how do you confirm diabetes mellitus? So there are 2 methods. One is patient is asymptomatic, second is patient with classical symptoms or crisis meaning patient may be having diabetic ketoacidosis or hyperosmolar hyperglycemic state. Okay, so when the patient is asymptomatic, you require among the 4 at least 2 abnormal test results. Now in that, if you are using the same test result, ideally it should be done some other day. The second test should be done some other day. If you are using 2 different test results, then if they are done on the same day also and they came as positive, then diabetes type 2 diabetes mellitus is diagnosed. But if one is positive, one is negative, then confirm with the positive test done on the another day. So that is how you diagnose diabetes in asymptomatic individuals, by using one of the 4 things. Okay, fasting plasma glucose, OGTT, HbA1c and RBS. Now if the patient is symptomatic, then just a random plasma glucose of more than 2 milligram per deciliter, single sample of more than 2 equal to or more 200 milligram is diagnostic of diabetes mellitus. That's all. So patient with symptoms, patient without symptoms. So with symptoms you require just RBS, and patient asymptomatic you can use either fasting plasma glucose, HbA1c or OGTT. But if you are using a single test, then and if it is positive, then you should confirm it on the second day, and if it is positive, then it is diabetes. If it is negative, then it is indeterminate. You can't say patient is having or not. Or if you are using 2 tests and one is positive and second is negative, then the test which is positive you repeat on the other day, and on the other day if it is positive, then it is known as diabetes mellitus. If it is negative, then it is again indeterminate. Okay, you follow up the patient after some 2 to 3 months, like that. So that is the funda of confirming diabetes mellitus, and these are the tests which are used for diagnosing diabetes mellitus. Okay, now while using HbA1c, remember what is HbA1c actually? HbA1c is actually the non-enzymatic glycation of hemoglobin beta chain, meaning glucose is attached to this RBC. So glycation of hemoglobin, actually the hemoglobin which is present in the RBC is glycated. The hemoglobin which is present in the RBC is glycated, and you know the approximate lifespan of RBC is 4 months. That's why this test gives you a understanding of glucose control of approximately 3 months. Okay, 3 months, because the lifespan of RBC is 4 months, approximately 3 months it gives. Now, but one important thing to remember is it can be misleading because it depends upon the lifespan of RBC. So where there is decreased lifespan or where there is increased lifespan, the HbA1c is affected. So that we should keep in mind. Now coming to when are the conditions when the HbA1c is misleading? So falsely low HbA1c occurs when there is accelerated red blood cell turnover. Accelerated red blood cell RBC turnover meaning old cells are going, new cells are coming, old cells are going, new cells are coming. So that is known as turnover. So when this turnover is increased, so you will have low HbA1c because old cells are going and new cells are coming. Okay, so that's why you are having low HbA1c, falsely low HbA1c. So this you can find in hemolytic anemias. Okay, acute blood loss. So in these conditions and recent RBC transfusions or pregnancy or erythropoietin treatment. So what is happening in these three? So when there is hemolytic anemia, the bone marrow is stimulated. When there is blood loss, the bone marrow is stimulated. When there is RBC transfusion, so you yourself is giving new RBCs to the patient. And when there is erythropoietin, again the bone marrow is stimulated. So when the bone marrow is stimulated, it will produce new RBCs and the turnover will increase. So when the turnover will increase, so falsely the HbA1c will be low. So you remember when these conditions are there, like hemolytic anemias, or when there is acute blood loss, or when there is recent blood transfusion, or if there is pregnancy also, it is a state of red blood cell turnover, and or if you are given erythropoietin treatment of the patient, then at that time you can have falsely low HbA1c. Then you can have high HbA1c, false high HbA1c also. When the RBC lifespan is prolonged, then you can have false high HbA1c. When it is prolonged, in iron deficiency anemia it is prolonged. Why? Because so the hemoglobin is less, the iron which is there in the RB is less, okay, and B12 also it is less. So when iron and B12 are less, remember the production of RBCs require, these are raw materials, iron or B12 are raw materials for the production of RBCs. When these are less, so immature RBCs will come into the blood, and these immature RBCs have a greater lifespan when compared to the normal RBCs. So that's why in iron deficiency anemia or B12 deficiency or in asplenia. So asplenia, why in asplenia? So remember, mainly the old RBCs are destroyed in the spleen actually. Spleen, they are destroyed by macrophages, old RBCs. So whenever for some reason, like for in thalassemia or due to splenomegaly, you remove the spleen from the body, so the destruction of RB is decreased, so lifespan will increase. That's why in asplenia you will have high HbA1c values. So why this matters? Because in these conditions, physicians, what they will do, they will not do HbA1c, they will do another test known as fructosamine test. What is this fructosamine? So this is nothing but glycated albumin. Albumin is, glucose is attached to albumin, so that is fructosamine. So this fructosamine provides a reliable assessment of mean glycemia over a 2-week period. 2-week period, that's all. When the HbA1c is invalid, you do a fructosamine test in this condition. So falsely, just to summarize, falsely low HbA1c in increased turnover, like in hemolytic anemias, erythropoietin treatment, pregnancy, and acute blood loss and blood transfusion, and falsely high iron deficiency anemia, B12 deficiency, and asplenia. Okay, there you use this your fructosamine test. That's about the diagnosis. How do you diagnose? Coming to the management strategy and target goals of management of type 2 diabetes mellitus. So just to summarize, management of type 1 diabetes mellitus requires, because there is absolute insulin deficiency here, sorry. So type 1 diabetes mellitus management is immediate start of insulin therapy, that's all. That is the main. In type 2 diabetes mellitus, there is a lot of stuff which we will discuss. So this stuff, okay. LADA is, I said, it is a type 1 diabetes mellitus of old adults, but initially these patients will respond to oral anti-glycemic drugs, but soon they will switch on to insulin, LADA patients. And one more thing is MODY, maturity onset diabetes of the young. Here the patient will very much, their patients are very much responsive to oral hypoglycemic drugs, okay, similar to type 2 diabetes mellitus. I said MODY is nothing but type 2 diabetes mellitus of the young, okay. And one more thing is pancreatic diabetes due to pancreas. So here you need to use regular short acting insulin, not long acting, short acting insulin, because it is brittle diabetes and there are a rapid fluctuation in the sugar levels in the patient's body, okay. That's a basic overview. Now coming to the management of the most common diabetes, that is type 2 diabetes mellitus in detail, okay. So we already know that the therapeutic management is shifted from just decreasing the number to CKM management, meaning cardiorenal metabolic focus. So that is one thing. Okay, so first we should have this CKM focus, meaning we should see the patient, whether the patient is having any comorbidity, cardiac comorbidity or renal comorbidity, or some metabolic comorbidity like MASH, meaning MSLD, fatty liver. If these are present, then specific drugs should be given initially only. But if these are not present, then you should decide based upon the patient interest. Like if the patient is having more weight, then you should start GLP-1 agonist. Or if the patient concern is having hypoglycemia, then you should give DPP inhibitors or DPP inhibitors and SGLT2 inhibitors. Or if the concern is cost, then you can give sulfonylureas, pioglitazone. Okay, that's so we will learn that in detail. So the first and foremost foundational thing which we do in type 2 diabetes mellitus is lifestyle modification, and the goal is to reduce the weight of the baseline weight of the patient by 5 to 50%. And the goal is to reduce the weight of the patient by 5 to 15% of the baseline body weight. So this is the number one recommendation by ADA 2026 guideline. Okay, so how do you do that? So our goal is to reduce the baseline body weight of the patient by 5 to 15%. Okay, 5 to 15%. How do you do that? By medical nutrition therapy and physical activity. In medical nutrition therapy, emphasis should be given on high quality, nutrient dense, low glycemic index carbohydrate diet. High quality, nutrient dense, low glycemic index carbohydrate diet, or you can say easily Mediterranean diet. Mediterranean diet should be followed in simple language, or otherwise you can say like this. So high quality, nutrient dense, low carbohydrate, low glycemic index diet should be taken. What should be restricted? So refined sugars, saturated fats, processed foods. So these should be restricted to the patients. Refined sugars, saturated fats, processed foods. Okay, so anything which is having a refined like your juices, canned foods, okay, which are having refined sugars, and fruits which are having high glycemic index, high sugar contained in them, those foods, they should be avoided, and processed food should be avoided, saturated fat should be avoided. So that is about the medical nutrition therapy. Okay, so one side you focus on the diet, on the other side what you do, you focus on the physical activity. So aerobic and resistant exercise is recommended. Aerobic and resistance exercise. So how much it should be done? It should be moderate to vigorous. So at least 150 minutes per week. At least 150 minutes per week, which should be spread in at least 3 days. Example, you split 150 by 3, 3 5 are 15. 50 minutes. 50 minutes 3 days of the week. For example, Monday 50 minutes, Wednesday 50 minutes, Saturday 50 minutes. So it becomes 150 minutes. So at least 150 minutes divided in at least 3 days. So that is recommended. Okay. And other thing which information which should be given is avoid prolonged sedentary lifestyle and break up shifting regularly. So by this medical nutrition therapy and physical activity, if one achieves if you take average 10% of weight loss, 5 to 15% of weight loss, then our goal is achieved. Then the patient should be said, you follow the same medical nutrition therapy and physical activity for your lifetime. So why this goal is recommended? Because it improves the hepatic insulin sensitivity. So if hepatic insulin sensitivity is increased, then your fasting plasma glucose will automatically decrease. Okay, and second thing is it dramatically slows the disease progression. Remember, the root cause of type 2 diabetes mellitus is adipose tissue, central obesity. This is the root cause of diabetes mellitus. Okay, now one thing I said that if by only medical nutrition therapy and your exercise, physical activity, if the patient has achieved 5 to 15% of weight loss, then it is okay. But if he doesn't achieve, or if the patient is having a BMI of equal to more than 27, then along with lifestyle and diet, you should advise patient pharmacotherapy for weight loss. So that can be given by GLP-1 agonists like semaglutide and tirzepatide. Patient should be given pharmacotherapy. Now again, if the patient doesn't respond to lifestyle, diet plus pharmacotherapy, then the patient is advised to undergo bariatric surgery. Okay, bariatric weight loss surgery, bariatric surgery, if targets are not met. So that is one thing. Or if the patient is having BMI equal to more than 30, then the patient is recommended to undergo bariatric surgery. Okay, so that is the first foundational first recommendation, because the main culprit of diabetes mellitus is your adipose tissue, your weight. Okay, along with that, we should counsel the patients also, because some patients have diabetes distress, sleep health disturbances, and they have a profound fear of hypoglycemia. Okay, so these should be addressed. These should be addressed. So what are the key takeaways in lifestyle modification? So cardiorenal risk reduction is the important thing. So integrated lifestyle management is essential always. The goal is to reduce the weight by 5 to 15%, and for that regular varied physical activity is non-negotiable. And if the patient doesn't respond, pharmacotherapy. Again doesn't respond, bariatric surgery. And you should also address mental well-being of the patient along with these targets. So that is the first recommendation. So after this first goal, 5 to 15% of weight loss, then you should shift to the pharmacotherapy of these patients, pharmacological management of the type 2 diabetes mellitus according to 2026 ADA guidelines. So now when you are giving pharmacotherapy, so weight loss is gone, when you are giving pharmacotherapy, non-insulin pharmacotherapy, that to non-insulin pharmacotherapy you should mention. So I should write here. So non-insulin pharmacotherapy, meaning drugs you are giving but it is not insulin. Okay, so first you should see whether the patient is having any comorbidity pertaining to heart, pertaining to kidney, pertaining to the metabolic syndrome. So if these comorbidities is present, so initially the thing was, historically, any patient universally you just start metformin. So that was the initial saying. Any patient who is diagnosed with type 2 diabetes mellitus, straightforward you start metformin universally. Okay, but it is not like that nowadays. Nowadays it is holistic, decoupled. It is based upon organ protection. So modifying the disease progression in the organ system. So based upon that, the decision is taken. It is not like directly metformin should be started. So first what you will see, you will assess the cardiorenal risk. Okay, cardiorenal risk, regardless of HbA1c or metformin use. So if the patient is having, so I will just zoom it. If the patient is having established atherosclerotic cardiovascular disease, meaning any chronic coronary artery syndrome, or if the patient is having a high cardiovascular risk meaning if the patient is elderly, age more than 55 years, or having risk factors like smoking, so which is a high cardiovascular risk, alcoholic, okay, obesity, hypothyroidism, okay, or dyslipidemia. So these are all high risk factor for cardiovascular disease. 1, 2, 3, 4, 5, 6. So these are all high risk factor for cardiovascular. If these are present, then the first line of drug of choice is GLP-1 receptor agonist like semaglutide, liraglutide, or dulaglutide. So this is, liraglutide is given daily actually, semaglutide is given weekly, dulaglutide is also given weekly, I think. Okay, so these are the first line drugs. Your regimen should include this GLP-1 receptor agonist. Or if these are not possible, because the cost of this drug is very much high, if GLP-1 receptor agonist is not possible, then you can give a SGL2 inhibitor like empagliflozin and dapagliflozin. That is one thing. So now, so this is before MI, okay, before MI. So after MI or due to some hypertensive heart disease, patient will have heart failure. Maybe reduced ejection fraction or midline ejection fraction or preserved ejection fraction. Reduced is less than 40%, midline is 40 to 50%, preserved is more than 50%. So in these patients, heart failure patients, SGLT2 inhibitors are the first line drugs. They should be present. Okay. Now some special note: if the patient is having preserved ejection fraction along with obesity, meaning ejection fraction is more than 50%, and along with obesity, meaning patient is BMI is more than 25. Okay, 25 kg per meter square. If this is there, if this is met, then in that condition it changes. You give GLP-1 receptor agonist, that is semaglutide. That is the second thing. Okay. The third thing is, now if the patient has chronic kidney disease, how do you diagnose? Albuminuria, in urine albumin is present, or the EGFR is decreased. Then again, now you can choose here. So in heart, you remember, if there is chronic coronary artery disease or high risk for cardiovascular, then first line is GLP-1, or if GLP-1 is not available, then at that time SGLT2 inhibitor. But in heart failure, the first line is SGLT2 inhibitor itself. Okay, except one special condition, this one. Okay, but in CKD, either you can use SGLT2 inhibitor primary as a primary, or you can use GLP-1 receptor agonist in CKD. Okay. Okay, now having this one is okay. Second thing is, you should assess the metabolic. You should see whether there is metabolic dysfunction also. How you will see? So this weight loss and all we have discussed. Okay, so metabolic disease you see by seeing the lipid profile of the patient, or whether the patient is having diabetes mellitus along with dyslipidemia, and if the patient is having fatty liver or not. If fatty liver is present, that means the patient is having a metabolic dysfunction. So in that case, the preferred drugs are GLP-1 receptor agonist and pioglitazone. Pioglitazone, it has a special property of mitigating fibrosis. Okay, so that's why you should have in your regimen of treatment this, either of these two, either the GLP-1 receptor agonist or pioglitazone. Okay, so now we have addressed the cardiac, renal and metabolic dysfunction. Now some patients will not have any of these. They will not have any established coronary artery disease or heart failure, or they are not high risk patient for heart failure, or they will not have CKD or metabolic dysfunction. So in that case, what you should do is, it is here. Then if if there are no comorbidities, then choose focus in that case. So if the focus is on weight loss, then give GLP-1 agonists like tirzepatide and semaglutide. If the focus is cost, then give metformin and sulfonylurea. If the focus is avoidance of hypoglycemia, like in elderly patients, so you should use DPP-4 inhibitor, GLP-1 agonist, SGLT2 inhibitor and thiazolidinedione like pioglitazone. Okay, so that's how you see. First you will see whether there is any comorbidity like CKM. If there is no CKM, then you choose the focus weight loss or hypoglycemia risk or cost. Then depending upon that, you choose the drug. Okay, now what are the targets? So now that is the thing which you have decided. So having decided, what are the targets now? So the target is according based upon HbA1c. The target is less than 7%. So you have addressed the end organ damage. Now we are focusing on the numbers now. So first of all, lifestyle modification, having a weight loss of 5 to 15%. Second, pharmacotherapy, non-insulin pharmacotherapy, type 2 diabetes mellitus. So first CKM focus. If there is no comorbidity, depending upon the focus, you decide weight loss, cost, or weight loss, cost, or something else, and then you focus on the values. So the target is less than 7% in general non-pregnant adults. strategy, how you bring down early combination therapy. If A1C is 1.5% above the target, meaning generally if you say, so if you add 1.5 to 7, it is 8.5. so if the HbA1c is more than 8.5%, that means you should start a combination therapy to the patient. Okay, so more than 1.5% of the target, you should start combination therapy. But see here, but this target should be individualized. So younger patients who have a low risk of hypoglycemia and newly diagnosed younger patients, low risk of hypoglycemia, tighter control is recommended, that is less than 6.5%. Now you add 6.5 to 1.5, so it becomes 8%. So if in younger patients who have a low hypoglycemia risk and newly diagnosed, if they have more than 8% HbA1c, you should start combination therapy. Less stringent targets zones like HbA1c less than 8% are recommended for patients who are frail, elderly, limited life expectancy, or who have severe complications or hypoglycemia awareness. Elderly patients with limited life expectancy, hypoglycemia unawareness, and severe complications. In those patients, the target is HbA1c less than 8%. Now you add 8 plus 1.5, so if it is 9.5. So patients in general population, HbA1c more than 8.5, start combination medications. In some special like young patients, HbA1c more than 8%, start combination medications. In elderly patients, more than 9.5%, start combination medications. Okay, so now target we have decided. Now we should address other factors also. The other factors are intensive BP control. So BP should be less than 130/80 in general, and lipid management is LDL target less than 80 in general. It is less than 80, and BP less than 130/80, but it is individualized. If the patient is elderly and complex patient, then priority is safety over strictness, safety over stringency, to avoid nocturnal hypoglycemia, to reduce death in bed risk, okay, in elderly complex patients. So along with this number of, you should also treat dyslipidemia and BP, and if the patient is hypothyroid, thyroid control should also be there, because if these are not controlled, then metabolic syndrome is not controlled in these patients. Now one more thing is to say here is, now this is about non-insulin pharmacotherapy. Insulin pharmacotherapy. So ADA 2025-2026 is recommending to monitor the blood glucose the patients who are using insulin by continuous glucose monitoring method. So some devices have now come up who monitor the glucose continuously 24 hours. So that method should be used. That is the mandate by ADA. So when it should be recorded? At onset, all patients who are on insulin, all patients who are on high hypoglycemia risk but not on insulin. Okay, so CGM is recommended, continuous glucose monitor is recommended in all patients who are using insulin, and all patients who are not using insulin but using high risk of hypoglycemia drugs, that is nothing but sulfonylureas. Okay, so that is the indication for CGM. So here we don't see that like fasting glucose target or PPBS target. Here there is something called as time in range and time below range, TBR and TIR. So TIR, time in range, that is nothing but glucose 70 to 180 milligram per deciliter. TIR should be more than 70%. So this will be shown in the machine itself. Okay, no to worry. And time below range less than 70 should be less than 4%. Less than 4%. Okay, one update. So okay, so that is about time in range and time below range, more than 70%, less than 4%. So now they are recommending, so all the insulin patients who are taking insulin, 2026 mandate is patients should use insulin delivery systems like insulin closed loop systems, like insulin pumps. They should use insulin pumps instead of injecting insulin. They should use insulin pumps. Okay, So optimal standard for type 1 and for those patients of type 2 diabetes mellitus who are requiring insulin. Okay, that is the thing. That's all. So how to give insulin? The mandate is by insulin delivery devices. Okay, I think you have understood a lot of things here. So now what is the target? So this is the last thing we will discuss, and we'll discuss other things in next video. What are the targets? In summary, the target goals for diabetes management: HbA1c, healthy adult, high risk or elderly, pregnancy or gestational diabetes mellitus. The target is less than 7% in healthy adult, universal, and selected patients like young, low hypoglycemic risk, newly diagnosed, less than 6.5%. In elderly, less than 8%. In pregnancy, it is less than 6.1%. Remember, pregnancy less than 6.1% GDM. Pre-meal glucose is nothing but that there is nothing such as called as FBBS or PPBS now. There is something called as pre-meal glucose, post-meal glucose. Pre-meal before food, post-meal after food. May it be morning, afternoon or evening. So the pre-meal glucose should be 80 to 130 in healthy adult, or in elderly it should be 100 to 140, and in GDM it is very much strict, that is less than or equal to 95. So 80 to 130, 100 to 140 and less than or equal to 95. Post meal glucose 1 to 2 hours after the meal, healthy adult less than 180, elderly or high risk patient less than 200. Pregnancy 1 hour should be less than 140, 2 hours should be less than 120. 1 hour should be less than 140, 2 hours should be less than 120. Pre-meal 95, 140, 120. Okay. Now if they are using continuous insulin pump like thing, closed loop system for delivering insulin. So you will see TIR and TBR, time in range, time below. So TIR in healthy adult it is more than 70%, TBR is less than 4%. Whereas in elderly it is more than 50% TIR and less than 1% TBR. Okay, more than 50%, less than 1%, more than 70%, less than 4%. Okay, for 50%, 1%. Now blood pressure BP should be less than 130 by 180 in healthy adult, high risk elderly less than 140 by 90. LDL cholesterol generally it should be less than 80 milligram per deciliter, but if the patient is having atherosclerotic cardiovascular disease, then the recommendation is less than 55 to 70. Okay, in elderly it should be individualized, ideally it should be less than 100. Okay, LDL should be less than 100 ideally. Okay, triglyceride level in healthy it should be less than 150. Okay, and in high risk elderly patient again it is less than 150 triglyceride levels. So the difference is in between just in LDL cholesterol. Now renal, so this we forget, urinary albumin creatinine ratio, UACR, or something known as UPCR also you can do, because UACR is not available everywhere. So UACR is a marker of renal health, no? So healthy adult it should be less than 30 milligram per gram, that means A1. Okay, and target again in elderly also it is less than 130. So triglyceride is 150 in both healthy and adults, and ACR is also less than 30 in both healthy and so difference is in BP and LDL. So these are the targets. So HbA1c you should see pre-meal glucose, post-meal glucose, TIR, TBR if you are using closed loop system, BP, LDL cholesterol, triglycerides less than 150 and urine ACR. So these are the targets. Okay, thank you. So this was the thing to be discussed, and other things we'll discuss in the next video.